Good morning, good evening, good afternoon. It's noon in Nashville, 1 p.m. in New York, 7 p.m. in Paris, 6 p.m. in London, 8 p.m. in Jerusalem and Riyadh. I'm Mohammed Moti from the Sorbonne University and Saint Antoine Hospital in Paris in France, and it is my great pleasure to introduce today this special webinar as part of the educational activities of the International Academy for Clinical Hematology. And the topic of this webinar is about GVHD in 2022, from prevention to therapy. And this will be delivered by a distinguished top expert in this field, namely Professor Bipin Savani from Vanderbilt University Medical Center in Nashville, Tennessee, USA. I don't need to spend a lot of time to convince this audience that after several decades of stagnation, actually the GVHD field has moved very rapidly in the last few years. In terms of prevention, we've seen prospective positive results with ATG. We have now post-cyclophosphamide being increasingly used not only in the haplotransplant setting, but also in the other donor settings. In terms of treatment of GVHD, we have ruxolitinib being approved now for steroid refractory acute GVHD. We have also some fascinating new molecules being developed, but also microbiota modulation. When it comes to chronic GVHD, we have now 3 drugs being approved by FDA for steroid refractory chronic GVHD, ibrutinib, ruxolitinib, and last but not least, recently, belumosudil. So you can see this is really amazing, and this is why Professor Savani has kindly accepted to deliver a state-of-the-art lecture summarizing for you all of this new research evidence and how this will impact our clinical practice. And as usual, the IACH webinars are live webinars, so please do not hesitate to send your questions, your comments, and I'll be more than happy to share them with Professor Savani at the end of this lecture. But for the time being, I'd like to welcome Professor Savani. Bipin, the floor is yours.
Thank you, sir. Thank you, Professor Moti. Good morning, good afternoon, and good evening, my friend in US, Europe, Israel, Asia Pacific, and Indian subcontinent. I welcome you all to this ISCH webinar on GVHD in 2022, from prevention to therapy. So I'm going to review very basic clinical information on GVHD prevention and therapy. We'll review some recently approved drugs. So most of you, there will be nothing I'm going to review which you don't know. But it is always important to review what is already known to us. A recorded session will be available on ISCH website, like Professor Moti mentioned. I would like to special thanks to my friend, our friend, colleague, well-wishers, who provided their slide to review this presentation today. I have no conflict of interest to disclose. And to be very specific, let me say, I don't have any stock in any pharmaceutical companies, period. So on part A1, we will discuss types of GVHD prophylaxis after reduced intensity. In part A2, we will discuss GVHD prophylaxis after ablative conditioning regimen. Slide reviews the basic information, very well known to us. Moderate to severe chronic GVHD is very common in about 20 to 30% of cases. But severe acute GVHD, generally less than 10% nowadays, because we're all smart in selecting best GVHD prophylaxis regimen nowadays. I'm sure we're all aware about this NIH criteria GVHD classification. In 2005, NIH Consensus Conference abolished the day 100 dividing line and redefined acute and chronic GVHD as a distinct clinical syndrome without time restriction. Although 2014 NIH Consensus Conference recommended that patients with late acute could be included in chronic GVHD trial with appropriate stratification. In practice, they are all usually excluded. I'll refer you all to this nice paper written by Stephanie Lee, published in the Blood. I give credit to NIH classification. We do have lots of multi-center national, international clinical trials. Participation of industry in this rare chronic disease is better than ever before. So let's start with real case scenario, RIC allotransplantation, and what should be our best GVHD prophylaxis regimen in patients receiving RIC allotransplantation for common myeloid malignancies. Many factors play in selecting GVHD prophylaxis regimen. This is a real case scenario. 69-year-old, history of AML, high risk, CR1 after induction and consolidation chemotherapy, no major uncontrolled comorbidity, 24-year-old, male, 10 out of 10, match unrelated donor identified, and decided to proceed with match-related donor RIC allotransplantation. So what is the best choice of GVHD prophylaxis regimen in this patient who is needing match unrelated donor RIC allotransplantation, peripheral stem cell blood graft? We always use PB graft, peripheral blood graft, for heme malignancy in RIC setting. So we have three options, rabbit ATG based conditioning, PTCy based, or combination of low dose ATG and PTCy based conditioning regimen. We do have lots of publication comparing PTCy with other GVHD prophylaxis regimen. I have selected this prospective randomized clinical trial to review the data today. This study was previously presented by Professor Moti, and I thank him for sharing the slide. Classical randomized phase 2b study comparing rabbit ATG versus PTCy using commonly used RIC regimen for hematological malignancy. Now, if you look at the EBMT and CIBMTR data, most commonly used RIC regimen in myeloid malignancy is flu-bu. Study included classical eligibility criteria reviewed here, and graft source only peripheral blood. Well-balanced patient and transplant characteristic between the group, flu-bu conditioning regimen with PTCy versus rabbit ATG-based GVHD prophylaxis using flu-bu again. To me, this is a better comparison than comparing Flu-Cy TBI 200 PTCy classic RIC haploregimen versus flu-bu rabbit ATG, especially when most centers are using peripheral blood stem cell graft. Let's review the result. Starting with most relevant adverse event, no differences in EBV CMV reactivation, hemorrhagic cystitis between the group. Also, no difference between the group in terms of severe cardiac events. No difference in risk of acute GVHD at day 100 post-transplant. There was a trend towards lower acute GVHD grade 2 to 4, and also severe acute GVHD trend towards lower in rabbit ATG arm compared to PTCy group. No difference in risk of chronic GVHD. extensive chronic GVHD between the group. Similarly, no difference in relapse incidence and non-relapse mortality between the group. Excellent 1-year survival in the range of 80% in both groups, considering these were all high-risk population. If CIBMTR was here to rank the program, I think their confidence interval falls into the +1 program. But there was no significant difference between the group. You have to have a GRFS data nowadays to get published manuscript in top-class journal. Composite endpoint of GVHD-free, relapse-free survival, meaning GRFS after transplant was no different between PTCy and rabbit ATG-based conditioning regimen. So what I can say here is, in patients using RIC regimen for hematological malignancy, PTCy is now well-established GVHD prophylaxis regimen in the hepto setting and beyond. But ATG-based RIC regimen are still standard of care at most center in patients receiving match unrelated donor RIC allotransplantation using peripheral blood stem cell graft. In our program for myeloid malignancy, we always use flu-bu-rabbit ATG-based RIC regimen with peripheral blood stem cell graft in patients receiving match unrelated donor transplant. We use PTCy-based GVHD prophylaxis only in patients receiving RIC haplo-PBSCT. My take-home message is, when old and gold standard RIC regimen works equally well, why do we need to change, right? Why do we need to change, right? I will only change my practice if I see superiority of other regimens compared to standard flu-bu-rabbit ATG in a gold standard clinical trial. Now let's review part 1B, GVHD prophylaxis regimen in patients receiving ablative regimen. A real case scenario, 49-year-old AML, CR2, needing allotransplant. 12 top 12 donor, unrelated donor identified and decided to proceed with ablative MURD transplantation. Our standard conditioning regimen in this setting for many years is flu high-dose BU, rabbit ATG for patients receiving ablative MURD PBSCT for myeloid malignancy. Now, question is, do we have other superior GVHD prophylaxis regimen among the different choices? So in 2022, we do have 3 choices listed here: rabbit ATG, PTCy, and Abatacept, Abatacept-based prophylactic regimen. Let's briefly review some data. There are lots of publications comparing PTCy-based GVHD prophylaxis versus ATG-based prophylaxis regimen in patients receiving ablative match unrelated donor transplant. Multiple comparative analysis from EBMT, CIBMT registry studies, and multiple ongoing studies. I selected our EBMT study for review here. Homogeneous registry-based large study. Study compared GVHD prophylaxis using PTCy or ATG in patients with AML who underwent allotransplant in CR1 from 10 out of 10 match unrelated donor. Outcome is similar in most published data. No significant, no statistical difference between PTCy and ATG group observed in this common transplant outcome, in comparing compound transplant outcome. And these results were also confirmed using match pair analysis. And these results highlight that in match unrelated donor setting, use of rabbit ATG for GVHD prophylaxis may provide similar outcome to those obtained with PTCy-based ablative conditioning regimen in patients with common hematological malignancies. So nowadays we have an option C, Abatacept. Abatacept is a selective co-stimulation modulator that binds to CD80 and CD86 on APC, thus antigen presenting cell. thus diminishing the CD28 mediated T cell activation. Now, blocking CD28 has been shown to prevent GVHD via control of T cell activation. In December 2021, just 3-4 months ago, FDA approved Abatacept for the prophylaxis of acute GVHD in combination with standard GVHD prophylaxis regimen using calcineurin inhibitor and methotrexate for patients receiving allotransplant from match 8 out of 8 or one early mismatch 7 out of 8 unrelated donor transplant. This is the first drug approved to prevent acute GVHD. Remember, we are using Abatacept for more than 3 decades. Not that old, but it's been the literature. PTCy based GVHD prophylaxis regimen for more than 2 decades worldwide. I don't think they need any approval. Both approaches are well tested. So ideally, I would like study sponsor to compare Abatacept with Abatacept or PTCy using commonly used regimen. To me, this is like, again, this is my personal opinion. This is like comparing chlorambucil with ibrutinib in CLL. I will let you judge. Let me review the data first. Abatacept efficacy was evaluated in 2 studies in patients 6 years or older undergoing allotransplantation from 8 out of 8 or 7 out of 8 unrelated donor transplant. Study number 1, GVHD1, study highlighted here. GVHD1 was randomized 1-to-1 double-blind placebo-controlled clinical trial using 8 out of 8 unrelated donor transplant using Abatacept or placebo with standard GVHD prophylaxis regimen with CNI, calcineurin inhibitor, and methotrexate. Severe grade 3-4 acute GVHD survival at 180 days post-transplant was not significantly improved in patients who received Abatacept compared to patients who received a placebo. You can see here 8 out of 8 match unrelated group. Severe GVHD was 6.8% among Abatacept group versus 15% in the placebo group. There are some issues here. I'm going to go more in detail soon. Let's review the first part 2 study. GVH2 part 2 study used CIBMTR data because sponsor had enrollment problem in patient who underwent 7 out of 8 match unrelated donor transplant. They used CIBMTR data receiving 7 out of 8 unrelated donor transplant between 2011 and 2018. Remember, they had to dig out 8 years of GVHD data from the registry to compare with Abatacept group. This registry-based study analyzed outcome of 454 patients treated with Abatacept for prophylaxis of acute GVHD in combination with CNI and methotrexate versus 162 patients randomly selected from CIBMTR registry treated with standard GVHD prophylaxis, CNI, and methotrexate. Grade 3-4 acute GVHD was 2.3%, which compared favorably with non-randomized match control cohort of CIBMTR group. And severe GVHD-free survival was better in Abatacept group. I feel this was comparison. This is like comparison between apple and orange to me. It's particularly part B of the study. And this is my personal criticism I'm going to review in a second. Now, if you look at the more in details, 8 out of 8 unrelated donor cohort, which is most common cohort, more commonly going to receive transplant nowadays. Let's review first study population. 73 patients received Abatacept versus 69 patients randomized to placebo group. Most commonly used regimen here are Bucy, TBIcy, and Flumel. We are high volume transplant program. Let me give you some more detail. We do more than 200 allo transplant every year. We rarely use BuPsy nowadays, based on published data. And TBI-Psi is disappearing, except rarely used in ALL patients, which again will disappear further because now we have a CAR-T approved for adult ALL. Other commonly used regimen in this study was Flumel, never used in my life. And if you look at the CIBM tier data, Flumel is used at a few selected transplant program in the country. Most commonly used ablative regimen to me nowadays is flu high-dose Bu. And in this study, only 7 patients received flu-Bu in a study arm, and only 2 in the placebo arm, and no ATG use in this population. My take-home message is I would like to see Abatacept compared with rabbit ATG, or comparison with PTCy-based GVHD prophylaxis regimen in commonly used conditioning regimen like flu high-dose Bu before I make any changes to my practice. And I also don't see superiority of PTCy versus rabbit ATG in patients receiving ablative match unrelated donor transplant. And therefore, we have not changed our practice. Our practice is to continue flu-Bu rabbit ATG, ablative match unrelated donor transplant, which we are very well versed and very experienced. So let's review part 2 now, therapy section. New standard of care development in chronic GVHD management. As we all know, chronic GVHD is common, mostly mild to moderate. I don't think we need to go more in details here. I'm sure you all are using NIH chronic GVHD scoring system. It's very easy, very reliable with a different hand, and very reliable on response assessment. Very easy to use, and believe me, sir. Why chronic GVHD is so important? It's a most frustrating chronic disease to treat if patient is not responding to therapy. Chronic GVHD has been linked to most late non-infectious and infectious complications, including psychosocial issues and quality of life. And it typically involves multiple organs at a time. Might be long-lasting injury or permanent injury to some involved organs. Heterogeneous disease, and understanding the pathology might help us select the best agent to treat disabling chronic GVHD early in the course. Now, risk of relapse-related mortality goes down over a period of time, right? But chronic GVHD-related late complication, including morbidity and mortality, not reaching a plateau even 10 years or 15 years or more after allotransplantation. Nice study published recently analyzed the association between chronic GVHD and non-relapse mortality in a recent cohort of 1,000 adult patients who received transplant and developed chronic GVHD, requiring new or change in systemic immunosuppressive therapy. Cumulative incidence of non-relapse mortality was about 25% at 5 years, increased and projected to 40% at 12 years, and maybe more than 50% non-relapse mortality in patients with chronic GVHD at 15-year post-transplant. And those patients with difficult to treat chronic GVHD manifestation of chronic GVHD was associated with increased non-relapse mortality. Let's again start with real case scenario. 36-year-old T-cell ALL, CR1, pre-transplant, had a Cy-TBI with testicular boot MUD allotransplant. Again, it was a long time ago, July 2014. We don't use Cy-TBI except rare indication like ALL with extramedullary involvement. Post-transplant course was complicated by severe chronic GVHD, skin score 3, musculoskeletal score 3, lung 2, mouth 1, and ocular 1 score. Severe joint and fascia involvement, severe contracture with significant impairment of range of movement, unable to do most activity without assistance. This is a young guy, young kids at home. Prior therapy, steroid, long-term, ECP, more than 1 year, had imatinib, had rituximab, 2 round, and most regimens in combination with ECP. So what do you recommend to this gentleman? We have now 3 FDA-approved choices listed here to treat refractory chronic GVHD. Let's review pros and cons of these 3 drugs. There are so many other in pipeline, but I will not do right now, non-approved drug yet. Ibrutinib was the first approved drug, first FDA-approved drug for treatment of chronic GVHD in 2017. Can you believe this? After almost 70 years of allotransplant era, we had a first FDA-approved drug to treat chronic GVHD. And I give lots of credit to NIH GVHD platform, chronic GVHD consortium, NIHD GVHD classification. Last year, we had 2 additional drugs approved to treat chronic GVHD. Ruxolitinib, similar to ibrutinib, after failure of 1 or 2 line of systemic therapy. Belumosudil for patients with chronic GVHD after failure of at least 2 prior line of therapy. We were major participating center in all 3 drug clinical trials. Again, credit goes to NIH GVHD classification, chronic GVHD consortium, and multiple NIH chronic GVHD guidelines paper. We will discuss ibrutinib first. Ibrutinib was designed as a selective and irreversible inhibitor of BTK protein, which plays an important role in B cell receptor signaling and activation of B and T cell. It was tested in phase 2 trial of only 42 patients with steroid refractory chronic GVHD, but it mainly consisting of inflammatory feature of chronic GVHD. Inflammatory feature of chronic GVHD, remember. Study resulted in about 67% objective response rate, and 70% of responders continued to show response for at least 20 weeks. Most common organ involved, mouth, skin, and GI tract. My main criticism here will be not well tested this drug in difficult to treat chronic GVHD. So what are the difficult to treat chronic GVHD? Lungs, fascia and joint, I mean musculoskeletal, ocular, I mean ocular fibrosis, manifestation of chronic GVHD. These are all very difficult to treat chronic GVHD. Ibrutinib, again, tolerance was an issue. Most common adverse reaction leading to discontinuation for fatigue and pneumonia. Second drug, ruxolitinib, is a JAK1/10 inhibitor. They suppress the T cell activation by interfering with cytokine receptor mediated signaling for variety of pro-inflammatory cytokines. It decreases the tissue damage and fibrosis. It impacts the function of dendritic cells, resulting in a decreased alloreactive T cell activation. Trial randomized 329 patients. We were also again a major center participating in this clinical trial. 329 patients, 1 to receive either ruxolitinib, 10 milligram twice a day, or best available therapy. Responses reviewed here. Continuation of therapy long-term is an important predictor of outcome. If I am able to continue therapy, it's the best predictor of outcome, because if you can't continue drug long-term with toxicity, you can't get response because you had to stop drug because of toxicity. And you can't help those patients with difficult to treat chronic GVHD because they take time to respond. 50% of patients had discontinued ruxolitinib. Most common reason for discontinuation was toxicity and lack of efficacy. Serious toxicity occurred in about 35% patient in both best available therapy arm and ruxolitinib arm. The rate of death also around 18%, comparable between the best available therapy arm and study arm using ruxolitinib. Belumosodium is an oral selective Rho-associated coil kinase 2 inhibitor. In contrast to ibrutinib and ruxolitinib, belumosudil was approved for chronic GVHD after failure of at least 2 prior lines of systemic therapy. Half of the patients had 4 or more organ involvement, including lots of patients. Again, I'm reiterating several times before. This study included lots of patients with difficult to treat chronic GVHD, like joint fascia, musculoskeletal GVHD in 63% of patients. Lung GVHD in cohort 1, 32%, and lung GVHD in cohort 2, 50%. Ocular fibrosis, which are also difficult to treat, 78% of patients. And overall, 78% of patients had severe chronic GVHD. For me, this is very important. Patient achieved in the study, patient achieved clinically meaningful result with belumosudil. Excellent responses, all reviewed here for your references. So my take-home message with belumosudil, I always look for opportunity to reduce steroid dosing. Long-term steroid usage, as we all know, very dangerous. 67% of patients on belumosudil reduced corticosteroid dose. 20% of patients completely discontinued corticosteroid, despite the fact that majority, 75% of patients had severe chronic GVHD. Corticosteroid dose reduction was observed across both responders and non-responders to belumosudil. It was well tolerated. As I mentioned before, ability to stay on therapy is dependent on safety and long-term tolerability of intervention. There was no CMV reactivation, no CMV infection, despite almost 60% of patients were CMV seropositive. Even in the absence of NIH-defined response, patient experienced clinical benefit, evidenced by improvement in Lee chronic GVHD symptom scale, we often call LSS, or patient had continued reduction in steroid dosing. Responses were achieved in patients with fibrotic manifestation in the lung, joint and fascia involvement, means musculoskeletal involvement, and eyes, ocular fibrosis. These responses were observed in some cases after more than 24 weeks of treatment, highlighting the need to sustain, need to continue effective therapy long-term to achieve clinical benefit, particularly in difficult to treat chronic GVHD. And we can continue long-term if they have a better safety profile. So back to our case, patient received both ibrutinib, more than a year, and then ruxolitinib off-label. This was before drug was approved. He was started on belumosudil in October 2021. As you know, it was approved in July. It took time to get this drug. You can see summary of 2 visits since patient is on belumosudil. He was seen first time 2 months after belumosudil, October, and seen on December, and then 3 months later in March 2022. Patient now is able to do lots of functional activity. Now on minimal steroid dosing, current dose is only 7.5 milligram. Significant result reduction in last 5 months. So this is my summary slide. Our approach in 2022. Being interested in late effect and late complication of transplant, I always love less steroid. Our approach in 2022 is less steroid. Immunomodulation, as opposed to immunosuppression. Multiple approved drugs now. And the most important is best documentation of GVHD, because regulatory environment, if you JC or FACT accredited program, as a FACT inspector, I always look at the GVHD, how they document, and also late effect. And this is a very important for regulatory requirement. If you are working on a clinical trial, you have to have a best documentation. Otherwise, garbage in and garbage out. So this is the best time to have a GVHD documentation. Compare, I compared my 10 years old GVHD note written like 10, 15 years ago, and I look at my current note, vast difference, made a difference when we have a best GVHD classification. We also have lots of ongoing clinical trial. At the same time, we do have a best supportive management innovation, best aggressive management of chronic GVHD related late effect in long-term transplant clinic, long-term follow-up unit, or GVHD clinic. It's all depend on what is your preferred name of the clinic. I thank you so much for your attention, and I'll be happy to answer if any question.
Thank you very much, Professor Savani, for really comprehensive, beautiful talk. Congratulations, because you managed in around 30 minutes or a little bit more to put together the clinical results data, but also how do they work in real life cases. So thank you for sharing these cases from your practice. And it is quite amazing, as you highlighted, how this field is moving in the right direction. We have plenty of questions. Unfortunately, we won't be able to take all of them. One question I have here from Dr. Well, it's going to be difficult to pronounce, Dr. Agnieszka Sobieraska. I hope I'm pronouncing well. And she's asking about whether, actually, given what you have shown with belumosudil, for instance, whether we should always use high-dose steroids in severe chronic GVHD with lung involvement, because at the end of the day, it's about trying to taper steroids very quickly.
So, in our practice, and I'm always against using high-dose steroid. I hardly and rarely use high-dose steroid. I don't remember when I used last time 1 mg per kilogram. A patient is on a clinical trial, definitely we need to follow the guidelines, and most clinical trial mandate to document high-dose steroid failure, and that time we use it. In a standard of practice, and when you go for insurance approval in the United States, you have to document failure from the steroid or poor tolerance, and we document that way. But yeah, I would always against using high-dose steroid for long period of time, brief period, 1 week, 2 weeks, and rapid taper, and add additional drug, especially for lung GVHD or difficult to treat chronic GVHD, is always good plan.
Okay, thank you very much. We have another couple of questions about MMF that you did not mention. Is there any role for MMF in chronic GVHD? I can guess your answer, but
BMT-CT ensured no benefit of all this regimen with or without sirolimus. I don't think so personally in terms of treating chronic GVHD. Prophylaxis, yeah, there are many conditioning regimen, particularly reduced intensity conditioning regimen, include as tacrolimus or cyclosporin and MMF versus tacro or cyclosporin and methotrexate as a prophylaxis regimen, not as a treatment part.
Thank you.
And I don't think I have ever used for the treatment of chronic GVHD. I'm talking about MMF.
I think we share the same approach. We have a question here from Dr. Priyanka Chauhan. What is the role of sirolimus in GVHD prophylaxis?
In haplo setting, there are centers they use sirolimus instead of calcineurin inhibitor as a prophylactic regimen, especially using PTCy based. Dana-Farber, they always use tacrolimus and sirolimus based GVHD prophylaxis use. But, again, like I mentioned several times, I would, and data are all more or less same. So I would use which is working best gold standard for my patient, which I'm very much versed with what I'm doing, unless some gold standard clinical trial showing that other approach is superior than what my approach is. We're also outperforming program like your program, 80% 1-year survival. And as long as we are doing good job with all these high-risk population and no proven data, other approach are better than our approach, I would use the same approach.
Thank you. Well, we have...
Thank you, Priyanka, for question.
Okay, yeah. So we have at least 12 or 13 questions about belumosudil. So I'll try to maybe to summarize. So one question is about, you showed nicely that among the three options, ibrutinib, ruxolitinib, and belumosudil currently approved by FDA, it is likely that belumosudil is the one that is working in lung chronic GVHD. So we have a couple of questions about this, and the questions are about, shouldn't we go for belumosudil there immediately?
Yeah, so, but currently we can't use in the United States because we have to follow FDA approved application if insurance payer is going to pay for the drug. But there is ongoing clinical trial and there should be lots of data coming out. That makes sense. Early use because safety profile is great, highly safe, highly safe. And many of Corey Cutler had presented data, he's the first author in the paper, that patients were continued even beyond so long after transplantation. So yeah, upfront is better. If you can get drug early, I think that's the way to go in a difficult to treat chronic GVHD. Again, lung GVHD, another difficult to treat GVHD, musculoskeletal, fasciitis, joint, and also ocular fibrosis. They can get better. And these are the area I would try to use early belumosudil if you can get it done.
Well, since you are mentioning early belumosudil, we have also a couple of questions because the label of belumosudil is after 2 lines of treatment, but actually, given the results, one may wish, and let's forget about the approval, to use it a little bit earlier. What
Correct.
are your thoughts about this?
I fully agree with you. It works. We were major participating center in that clinical trial. I use it in those patients. I'm using it only in those patients who failed previously ruxolitinib or ibrutinib. It works very effectively. And I strongly, once we get approval, it will be easy for us and our patient.
So we have a few questions about the availability of the different drugs, ibrutinib, ruxolitinib, belumosudil in different countries and different places, and the status of approval. So guys, I do apologize. This is beyond the scope of this webinar because, of course, and I would kindly ask you to see with your whoever local representative of the relevant company for these drugs to see the status in your countries. Okay, so here we have a question, and unfortunately, I'm not able to pronounce the name, so I'll skip the name of the colleague because, so it's about the sequence of the drugs that are approved now in steroid refractory chronic GVHD.
Sequences?
Are there any sequence, for instance, you would prefer to start with ibrutinib or ruxolitinib, then move to belumosudil, or how are we going to handle the sequence?
So, let's start with ibrutinib. It was well tested in inflammatory type of chronic GVHD, mostly skin, oral cavity, some GI and liver. So those cases, I would prefer to start with ibrutinib. Other cases, if patient meets, and if patient has, this is the standard. And then if patient has a difficult to treat chronic GVHD, like I highlighted before, and patient meet the criteria, I will go directly to the belumosudil without wasting time. Ruxolitinib, as you mentioned before, if you look at the 2 point, discontinuation of best available therapy versus ruxolitinib was 50% or higher in both groups. Rate of death in both groups was also identical, best available. So tolerance is an issue, infection is an issue. But I would still consider ruxolitinib and not a difficult to treat GVHD, and they're not qualifying for belumosudil. Belumosudil is so easy to use, don't require close monitoring, no infectious issues. In ibrutinib, our clinical standard of practice, if we start, I'm talking about ruxolitinib, Rux. If we start Rux in a patient with chronic GVHD, we have to start letermovir. This is our standard of practice because patient can get late CMV reactivation on Rux. So it's all complicated issues, infectious issue, viral monitoring. And this is my personal opinion. Again, I do not have any stock in either of these companies. And our goal is to get best for the patient.
Excellent, thank you. And by the way, thanks to Google Translate, I was able to find the pronunciation of the colleague who asked the question. So this is Dr. Sergey Krutsev. Thank you, Sergey, for raising this excellent question. One last question about the future, Bipin, and this is from Dr. Panayotis Kaloyanidis. And this is about the role of cellular therapies in chronic GVHD. And for instance, now we hear about regulatory CAR T cells. Any thoughts on this, or maybe specific graft manipulation? Maybe this is science fiction, but who knows?
Let me, first of all, this is a long question and difficult to answer in a sentence or two. But, SEG, we have done recently ISCH ASH 2021 webinar, just completed in January. And I discussed all the cellular therapy used in a transplant patient, including for those with chronic GVHD. But to me, ORCA, Treg cellular therapy preventing GVHD from Stanford regimen, I'm very impressive, and we are participating in the clinical trial. But I don't think anything more than this I can explain here. I can answer here.
Wonderful. Thank you very much again, Bipin, really, for this lovely and beautiful webinar, state of the art. And the field is really moving rapidly and nicely. Lots of hope for the patients who are really struggling from chronic GVHD, which alters actually the quality of life. I do apologize to all those colleagues because we're not able to take all the questions. Dr. Leota, Dr. Jost, all of you, I do apologize, but you can write to Dr. Savani directly with your questions. So thank you very much. I hope everybody has enjoyed this special webinar brought to you by the International Academy for Clinical Hematology. And as usual, I take the opportunity to thank all our sponsors who are allowing us to run all of these educational activities in a non-profit fashion, open worldwide to all audience. I think we had more than 60 or 70 different countries represented tonight, or this morning for you, Bipin, tonight for me. So really thank you. Thanks to Amgen, thanks to Sanofi, thanks to Takeda, thanks to Janssen, all our supporters. And I'm sure I'm missing many of them. You can see them on the website. So thank you very much, and thank you for your loyalty. And I hope to see you soon in another ICH activity. I guess we will have soon a journal club and many other activities. So for the time being, wherever you are, please stay safe and keep well.
Thank you. Thank you.